Welcome to this National Academy's workshop on developing a patient-centered approach to optimizing veterans' access to healthcare services. I'm Dr. Ken Kaiser and have had the privilege of chairing the planning committee and will be moderating this first session and piping in intermittently through the session and then doing some closing comments tomorrow. I want to take this first few minutes just to make a few administrative type comments to let everyone know some of the rules of engagement, if you will, and then we'll make some other comments before passing it on to the other participants in this opening session. So, first thing I would note is that this is an open on the record session, and what is said will be recorded and will be used in preparing the summary document that will come out of the workshop, the proceedings of the workshop, if you will. If there are questions as we are moving along, as I anticipate there will be lots of them. Please submit those in the discussion box underneath the live screen. And when doing so, please make sure that you also include your first and last name and your affiliation. I should also make sure that everyone understands that this session is being recorded and that after the workshop is concluded, it will be available to the public and will be maintained in the National Academy's archives for however long they maintain such. So it will be available for people to access and look at in the future if they're not able to participate. I would also note that the Academies has had some unexpected and unplanned IT challenges over the course of the night, and hopefully those have been largely worked out by this point, but it's possible that that may complicate things a little bit as we're moving forward. And I suspect if you are like me and have participated in a lot of these meetings over the last 3 or 4 months, that this is not an unheard of situation, but that we will muddle through it and hopefully produce the best possible outcome that we can. So with that, let me move into just some introductory comments and try to set the stage a little bit before I pass the baton to Drs. Kirsch and Matthews and others who will be participating in this opening session. If for some reason there, okay, I'm having a little technical issues here on my end, but anyway, so this workshop, which is being brought to us by the Department of Veterans Affairs, we're going to look at a number of things over the course of today and tomorrow. We will particularly focus on what are some patient-centered methods to optimize access to high-quality healthcare for veterans, which means that we're going to have to talk about things like, well, what does access to care mean? How can that be measured in ways that facilitate accountability for the organization? What are some strategies that can be utilized to optimize access and things that specific things that VA might do to improve access to care? Particularly, we want to also focus on some of the special patient populations that VA has and ways to make sure that those special patient populations have timely access to care. I could have the next slide. So as I said, the sponsor for this workshop is the Department of Veterans Affairs. They are the sole sponsor in this case. Many workshops have multiple sponsors, but in this case, the VA is our sole sponsor, and we thank them very much for supporting this effort. Next. Just very briefly, we had a very talented and experienced planning committee that has put forth the program over the course of today and tomorrow that you'll be participating in. My privilege to chair the group. You will be hearing from many of the persons indicated on the screen as moderators or speakers of the session. Unfortunately, some of them were not able to join us today. I should probably note that this workshop was originally planned for early March, the beginning of March, as an in-person session, but some other events have kind of complicated that and has required that it be delayed, and it's now a virtual event, which did mean that some changes in the schedule and who could participate were involved. It also has shifted the nature of the conversation a little bit, as we will talk about going forward. Next slide. So let me just briefly raise a couple of points that will be talked about more as we move through the sessions today and tomorrow. Next. Go to the next slide, please. So, this is a workshop on how do we improve access to care in the VA, which then kind of raises a threshold question of what do we mean by access to care, and particularly what does that mean in a way, and can we define it, conceptualize it in a way that facilitates measurement so that we can ensure organizational accountability for access. So in doing that and looking back over the literature over the past several decades, and I would say that there has been a lot. Access has been talked about a lot. Lots, scores, hundreds of articles, and other occasions. But the one thing that consistently comes out of that there is no single definition for what we mean by access to care. I show on the screen here some of the ways that access to care have been defined over the years, going back to the early 1970s. And as you can read this, these definitions aren't quite the same, and they don't necessarily define it in a way that lends itself easily to performance measures or other ways of ensuring accountability if an organization is going to be held accountable for access. Next slide. I would also note, and I'm making some very brief comments here on these issues because we're going to come back and talk about these in a lot of different ways over the course of today and tomorrow. But it turns out, not surprisingly, that access is pretty complicated, that there's a bunch of things from, if we think of it as a supply-demand equation, that there are a bunch of things on the supply side that affect whether one has access, the number of facilities, the number of staff, other things from supply side. Likewise, there are demand side, how many patients are seeking care, for what type of care, or what type of technology or types of problems that they may have can certainly change what is needed on the supply side as well. We also know that there are a lot of process factors that may affect how accessible care is. Do people answer the phones? How easy is it to schedule appointments? Do we have to have in-person appointments, or can we look at virtual methods? And again, the list is long, but there's lots of process things that affect whether one has easy access or not. And then there's also the kind of the threshold question of, okay, once you have access or that you can get into the system, do you have access to what's most appropriate for that person? And I think this is particularly important in thinking about the VA, insofar as does the provider who is seeing the patient, do they understand the types of issues that the veteran come with? Do they understand some of the particular situations and circumstances that the individual or that might influence the problem that the individual is presenting with? Things that one might not think about if they're not familiar with the settings in which veterans have served and the particular circumstances in which they have lived through that may affect what they actually need in the way of care. So again, we're going to delve into these in more depth as we go forward, but there's a lot of complexities in thinking about access. Next slide. So just one other kind of background slide in the way of providing some situational context, if you will. And that is that VA is required by law to track and publicly report its wait times for access to care. Insofar as wait times is the agreed upon metric to date that has been used to hold the organization accountable for access to care. And VA, as said, are required to both track and publicly report it, and then to compare them to private healthcare systems. Although private healthcare systems are not required to track and report their wait times, which makes it a bit complicated when you're trying to refer patients to community providers based in large part on what is the relative ease of access or timeliness of access in the VA versus the community. And Dr. Matthews will be talking more later about the community care program and some of the issues attendant to that. And also, as I've already noted, there's no, even if the private providers were tracking and reporting their wait times, there is not at this point or this juncture in time a standard approach or framework for defining and assessing access to care, as was already noted, nor is there any standardized nomenclature to be used in defining what timeliness of care is. Indeed, while VA is required to track and report wait times and compare those to the private sector, there is no standard agreed upon definition for what a wait time is, and that variable definitions and ways of measuring this are used in the community. And perhaps not surprising, because of some of these complexities and difficulties in measuring it, stakeholders often find the VA's data about wait times difficult to interpret and confusing and sometimes not reliable. And that we're going to get into some of those issues as we go forward as well. So if I could have the next slide. So basically, I'm going to come back just to talk again about some logistics, administrative things. We are going to try to set the stage and amplify on some of the things I've called out in the past few minutes in this first session. And then we will have 3 other sessions today that will focus on some other issues. Dr. Beinman from UCSF will be leading the panel and discussion on strategic considerations for conceptualizing access to care. We'll take a lunch break, and then we'll come back after lunch, and Dr. Lisa Rubenstein from RAND will be talking about some of the operational and tactical considerations for measuring access. We'll take a short break, and then we will conclude the day with Dr. Al from University of Washington talking about increasing access to, or increasing capacity for access. And then tomorrow morning, we will come back and start the day at 10 o'clock with Dr. Jeanette Southpaul from University of Pittsburgh talking about ensuring adequate and timely access for special populations, VA special populations, and we'll talk more about what those populations are tomorrow. And then we will conclude the panel sessions with Dr. Heather Young from UC Davis, talking about or moderating a panel on the stakeholder perspectives on the discussion and priorities in moving the path forward. And then we will conclude the day with some summary statements. Dr. Pryor is going to join us. Dr. Pryor, former CMO from Ascension Health, will make some comments, and then Dr. Kirsch and I will try to make some wrap-up comments and conclude the day. Along the way, we will be having a lot of discussion, and hopefully we'll be able to have that discussion. Indeed, much of the value from these workshops comes from the robust discussion that typically occurs. Because we're doing this virtually, it may be a little bit more challenging than in person, but I'm confident that we will work through that. And at some point, several weeks after the conclusion of the workshop, there will be a proceedings or summary of the workshop will be published and will be available, as will the full recording of the event. So with that, let me just again remind you of some administrative things before I turn the microphone over to Drs. Kirsch and Matthews, who will be talking about some things from the VA's perspective and providing some background. I want to, so we can go ahead and move control of the slides to whoever's going to control that for them. I do want to remind folks again that this is an open on the record session. This is being recorded. The recording will be maintained and available to the public afterwards, and that any discussions that one might want to submit should be done via the discussion box underneath the live stream. And I think with that, that concludes all of the comments I wanted to make to launch us off. And I will turn the mic over now to Drs. Susan Kirsch and Cameron Matthews at the Department of Veterans Affairs.